I think you will all agree that it was a patient-centric approach adopted by Dr. Krishnan to highlight the scope of introducing the molecules after metformin. So even though the discussion boiled down to a couple of molecules in contemporary diabetology practice, I think you utilize the opportunity to focus on the entire gamut of type 2 diabetes mellitus in the sense that elderly as well as young, very old as well as middle-aged, and very lean type 2 diabetic subjects as well as old with comorbid conditions. So the spectrum of diabetes mellitus, in other words, from the young non-obese or obese diabetic to somebody with complications in elderly age, in the huge spectrum, probably the molecule that addresses the issues from the point of glycemic advantage are the DPP-4 inhibitors. I think that message has been driven very beautifully. You did draw a beautiful distinction between cardiovascular outcome trials, the endpoint, and the various phase 3 trials or the other data wherein glycemic endpoint has been captured, which is probably relevant in the early part of the disease. And finally, when you talk about diabetes, which is a combination of insulin resistance and secretory defect, when there is consensus about addressing the insulin resistance, namely with metformin, why should we hesitate addressing the secretory defect, which is the major pathological contributor type 2 diabetes mellitus. Thank you once again, Uni. Now we go on to the next talk. Brief introduction. I'll just take 2 minutes. Thanks to severity trial and SAXA, we heard an entity called cardiac failure. Not that we as physicians and diabetologists are unaware of this complication. So when hospitalization for cardiac failure was associated with severity trial, I think all of us were really looked up to what is this heart failure. Then thanks to the severity trial, I'll tell you. Maybe cardiologists, you know much more, and you have highlighted it. For physicians, diabetologists, endocrinologists, maybe we relearned our physiology. We knew how cardiac failure can impact and how it can be one of the earliest presentations in the diabetic cardiac presentations, unfavorable cardiac presentations. And then after the SGLT2 inhibitors, I think as I keep on telling, we just keep our head in high and then say, okay, we have an anti-diabetic drug, which is as good, if not even better than the conventional drugs that we use in. So to do more about this on this particular very important topic of diabetes, heart failure, and prevention of its progression, a guide with focus on SGLT2, we have Tiny Nair. I think his CV, can you have the CV? Only the name and the CV are tiny. His knowledge, his orational skills are, I tell you, mega. I have listened to him. We have listened to him in the HDL symposium. I always love listening to Tiny. He is the head of the department and consultant in cardiology in Trivandrum. He has authored 5 books and then 50 publications in reputed journals, most inspiring doctor award India, and best reviewer of annals in internal medicine, and best doctor award, not surprising to me, from the government of Kerala. Tiny to you.
Thank you so much for that excellent introduction. Oh, no, not really. I'm short, but I think not too short. Thank you. Yeah, that's good. That's good. First line is blank.
It's blank.
Yeah. Okay. But it does not come there. No. Good morning. Good morning. Thank you. Please wake up. On the left side of your screen, you see one of the top-rated states, countries of the European Union, Sweden. And on the right side, you see bottom, you see that small patch, red patch, and that is the state of Kerala. Now, the point is, they are obviously diverse, and we'll see how we connect 2 of them in the topic that we are going to talk about. But first, look at the differences, right? Sweden is 400,000 square kilometers, huge country, and only 10 million people. In contrast, you have Kerala of 40,000 square kilometers and jam-packed with 40 million people. No space to move, right? But then the point is a lot of similarities. In fact, if you see Sweden, 2/3 of Sweden is green, 2/3 of Sweden is green, and 53% of Kerala is green. In fact, that is the aerial photograph of the town from which I come, Trivandrum, and that is how it looks like. It's all green, right? But then point is, if we look into the health parameters of both, life expectancy at birth in Sweden is 82, and it is, this data is not Kerala, but Trivandrum. Trivandrum life expectancy at birth, we have the data published now, is 79, fascinating. All India is 68. We have the infant mortality rate, which you all quote that, and that is 5 for Sweden and 5.9 for Trivandrum, 5.9, fascinating. All India is 32. Fertility rate, 1.8, we match them, right? So we match them quite a few parameters, but there is something amiss. This is somewhere a point where we go different, right? In Sweden, you have something called an 1177. 1177 is the network of everything. You connect, you look at the patient on top, your physician, your employer, whatever. You look at the discharge data. Anywhere you go and get in touch with the medical system, your data goes into the network. You go and buy an analgesic, or you go for change of your glasses, your data gets into the system. And that is a fascinating system. And not just that, the government allows every Sweden citizen an access to the electronic health records, provided you go and prove as to why you want the data, for what purpose of analysis. And that is where we go back. For example, if you see, that is all the network that we have in Kerala, a lot of fishing nets, right? That is all the network. And if you say, what is your electronic network from medicine? This is the best working electronic network in medicine in Kerala. I get ECGs from the ICCU duty doctor through WhatsApp, right? So I think what we lack is the, where we go back, is the problem of networking. We have excellent private hospitals and government hospitals in Trivandrum. None of them are networked, right? Oh, sorry. But none of them are networked, and so we are not sure as to what data is happening in the other place. Now, let's start with Sweden. This data came about a year back in NEJM from Sweden that has 271,000 diabetic patients from the Swedish National Registry. A fascinating data, perhaps every one of you would have gone through. Let's revise that. They looked at 5 clear risk factors, the A, B, C of diabetes. A1C, blood sugar, B for blood pressure, C for LDL cholesterol. And to that, they added microalbuminuria and smoking. So A1C, blood pressure, lipids, microalbumin, smoking. And they tried to see what impact these 5 risk factors had on cardiovascular outcome. And the results are fascinating. I think this is a take-home thing that we should all learn. For example, if you look at excess acute myocardial infarction, right? And look at those who are not diabetic. Obviously, those points are right on the line, right on the center line, right? But when you had a diabetic with no risk factors, none of those 5, all 5 controlled, they are still on the straight line or even slightly on the left. Okay, so that is extremely interesting. In contrast, if you have all those 5 risk factors abnormal, look at that. The risk factors goes from 3.19 to 7.6. And this is interesting because all these years we told our students that diabetes equals myocardial infarction. Okay, the same risk, it is not. So the conclusion, the article said that type 2 diabetes who have 5 risk factor variables within the target range, well controlled, there appears to be little or no excess risk of death, MI or stroke. So if you control those 5, A1C, blood pressure, lipids, microalbumin, smoking, the risk of cardiovascular event rates are extremely low. That's good news. But pertaining to our topic today, this is what is the bad news. If we look at heart failure, for example, heart failure, that is the control. If every risk factor is controlled, still the risk of a 55-year-old man for developing heart failure in a well-controlled diabetic with ABC, microalbumin, smoking controlled is what? 2.4. So in the background of heart failure, we have not achieved anything at all. From the Swedish data, come back to Trivandrum. This is the data we are always proud to show. This is the Trivandrum heart failure registry, one of the few good registry data that whole world accepts, which has come from Trivandrum. Just look at one thing. We are proud because this came in American Heart Journal. Oh, when they accepted it, we were like, oh my God, American Heart Journal accepted our data. Now the point is, if you look at our conclusion, cumulative all-cause mortality at 1 year was 30.8%. Can you believe it? Heart failure mortality is 30% at 1 year. So that is what we say. And not just that, unlike the Western registries, most of our patients had a prior myocardial infarction. Please. Prior myocardial infarction. So, when we compare Sweden and Trivandrum side by side, heart failure mortality in Sweden is 15% roughly, and ours is 30%, just double. So we have a big problem at hand, and that brings us to the topic that we are going to do in the next maybe 15 minutes on diabetes, prevention of progression of heart failure, and where does SGLT inhibitors come into the picture. We'll just take a couple of points. Before that, let us just revise quickly as to what we know. From the huge data we have today from Empower, Canvas, and Declare, totaling about 34,000 patients, if we look into the heart failure, hospitalization, and of course cardiovascular death, we see that heart failure hospitalization in this 3 trial in patients who came in with heart failure, there were only few, about 10%, had a reduction of event rate of 29%, right? That diamond is on the left of my line. Those who came without a heart failure, like any diabetic walking in, they had a reduction of 21%. So good reduction by SGLT inhibitors, all 3 worked. Now, next came DAPA-HF, which very clearly told us that if we take patients of heart failure, and as we know about 50%, 58% of patients of DAPA were not diabetic, DAPA-HF. And still we find that there's a significant improvement of primary outcome of cardiovascular death and heart failure hospitalization on giving SGLT inhibitors in a heart failure background, diabetic or no diabetic, 26% benefit. And this is what we already talked about in every forum, that yes, whether you are a diabetic or no diabetic, the benefit was equal, roughly about 25 to 26%. So this is what we already know. So where is SGLT, the whole arena? Okay, right, this is here. If we look into the terminal part of heart failure, we know that unlike any other disease, heart failure graph, as you can see there, has all those dips. Those dips are when the patient is fine, suddenly develops an acute pulmonary edema, comes to the ICU, he's sick, bad, BiPAP, oxygen, he becomes better after a little bit. 2 days later he goes home, but he's little down. Till the next admission with acute pulmonary edema in the CCU, right? So his graph is like that. So today we know that DAPA-HF has shown that we can push that graph there, we can reduce mortality. We know that we can reduce the heart failure hospitalizations, yeah? SGLT inhibits, prevents, and benefits by reducing heart failure hospitalizations. But what we often don't realize is that most of the heart failure, as we have shown in our Trivandrum heart failure registry, comes from ACS. And SGLTs prevent ACS. We know that they prevent events, right? They prevent events. So SGLTs prevent ACS. Not just that, we know that there's a huge amount of comorbid condition that pushes a patient for an ACS, risk factors and comorbid conditions like type 2 diabetes, hypertension, obesity. So you can see today, starting from just risk factors to an ACS, to LV dysfunction, heart failure, and terminal death, every arena we have data to show that SGLT inhibitors benefit. We know all that, but what we would do is, so this is what we know, and there are some things that we don't care to know. There are 5 important topics that I've chosen out where we don't know, I don't know the answer clearly. Maybe you can all help us finding an answer, but they are very interesting, and think about it. Number 1 is post-bypass surgery. See, post-bypass surgery, all patients, talk to anybody who had a successful bypass surgery, will come and say, doctor, I'm cured. I had 5 blocks, Dr. So-and-so bypassed, I am fine. Yeah, and the doctor is also, I'm also happy, the cardiologist is happy because I put him on RAS inhibitors, beta blockers, statin, antiplatelets, because he had a major surgery, he will take all that without any break. Every 3 months he sees me, right? So he's fine, he's cured, we are happy, patient is happy. But when we took out that kind of data, those who had CABG before, we had taken out the data from the Empower outcome trial and found it was surprising that the top blue light line is placebo and bottom line is empagliflozin. We found that there was a 50% reduction of heart failure hospitalization over the course of time, right? And not just that, they had reduced nephropathy, they had reduced MACE, all-cause death, cardiovascular death. But we are today talking only about heart failure progression, right? So there's a tremendous change of their outcome of these patients who apparently come and tell you and me, oh, doctor, I am fine, I am eating all the medicines and fine, he's not fine. So probably that is an area where we should think about introducing an SGLT2 inhibitor, whether he has a symptom or no symptom, whether he has an LV dysfunction, no LV dysfunction to start with, and he might actually do better in the long term. Think about it. Point number 2 is the obese heart failure patients. A lot of patients come with obesity and say, doctor, I just can't walk. An echo is done and looks like apparently normal. We just say, oh, you lose weight. What is this? You reduce your diet. They are neglected. They love that, right? But it's not laughing matter. It's not that single person who is extremely obese standing away from the crowd. Today we know that 73% of urban Indians are overweight. So obese heart failure is a real challenge, and we have very little of it. I'm happy that Dr. Unikrishnan and your team, you had Dr. Ekedas is there, all of you are there. You did your positioning statement and Indians extremely well that came in diabetic therapy, and you are focused on abdominal obesity. I'm happy about that. This is one thing that is neglected. Just about a year back, the Journal of American College of Cardiology, Professor Milton Packer wrote an extremely beautiful article with ideas as to how we can try to look into obesity heart failure. Very interesting. They point out that present research looks like we should target three areas. One, and they're new, at least to me it's new, I think it should be new for you too. One is neprilysin inhibition, ARNI. Obese heart failure patient might benefit, looks like, from ARNI, that is sacubitril valsartan combination. Second, they tend to benefit with melanocorticoid receptor antagonists, aldactone or eplerenone. And third, they are likely candidates for SGLT2 inhibition. So think about it next time you see an obese patient coming with difficulty in walking, COPD has been ruled out, and diastolic dysfunction, you're suspecting might be some kind of HFpEF. Think about neprilysin inhibitor, think about melanocorticoid inhibition, think about SGLT inhibition. A lot of people say, okay, you go to all forums and talk about empagliflozin in improving cardiac outcomes. Did you ever see a left ventricle in front of your eyes in the echo who has taken SGLT2 inhibitor improve? We didn't have an answer till recently. Till last ACC, we saw the EMPA heart coming in. Very interesting data, empagliflozin data on left ventricular structure and function. Very small study. Actually, it's such a small study that it doesn't even come into the mainline presentations. 423 patients, 152 consented, and finally you had about 50 in placebo, 50 in EMPA. Very small data. But interesting thing about this 50-50 is that these patients, all of them had a detailed cardiac MRI done. And today, as you know, like we say always, that cardiac MRI is a far better sensitive tool in assessing left ventricular function compared to echocardiogram. Okay, they are far more sensitive. And in this trial, very clearly, there has been reduction of left ventricular mass index in the empagliflozin group, and there has been an improvement of the ejection fraction, small amount, but very clearly the left is placebo, no change, while in EMPA there has been an improvement in ejection fraction. So it does change, yeah. If you have the tools, sensitive tools to look into it, it just show you that it changes. People ask us that, okay, tell us what kind of ejection fraction patients benefit with, let's say, SGLT2 inhibitor, empagliflozin. Would it be somebody who has an 18 to 20% EF, very bad, or is it 40, 45%, or is it that normal ejection fraction? Till recently, we didn't have a data. This is an Maccabi Healthcare data that is an insurance database that came from Israel by Dr. Koseborod, and this very interesting. That was presented in ACC again last time. Very clearly, if you look at the all-cause mortality, for example, and look at the y-axis at the rates per 100 patient years, you see that whether it is reduced ejection fraction, the SGLT is in blue, or whether it is preserved ejection fraction, everywhere there's a benefit over the gold standard control group when you add an SGLT inhibitor. So obviously, the benefit is likely to be less as the ejection fraction becomes better and better and better, obviously, but it does show clearly that there is a benefit. Probably 2020 end, we would get the Emperor database when we can clearly tell you whether it benefits HFpEF. Now, this is interesting. Always endothelial dysfunction had been something like a big theoretical. It is theoretical, but let us see something that has come very recently and so very interesting, I thought we should present it. This is a connection between the endothelial dysfunction and cardiomyocyte. Very interesting. Look at how the trial is done. I found it fascinating. They took some endothelial cells and cultured them in a pot with a lot of holes in the bottom, sieve, right? That top one, top box. And they gradually put this box down into another culture broth where at the bottom they have cardiomyocyte, muscle cells. So bottom is, that line is cardiomyocyte, so that top line is endothelial cell, the bottom line is cardiomyocyte, right? So they put it like that. So both are cultured. It is not a simple thing, it's a very complex system. You see the cartridge looks like this, and they clearly tell how it was lowered and how it was done. But in sum and summary, after that, they paced the cardiomyocyte, and looked at how well the cardiac muscle cell contracts. So is it good? It is very strong or what? So they looked at the contraction of the cardiomyocyte. And this experiment was done by infusing into the broth either TNF alpha or empagliflozin. And look at what happened, very, very interesting. So the point is, when the endothelial cell is brought very close to the cardiomyocyte, endothelial cell produces nitric oxide, those blobs in blue, they go and stimulate and benefit the cardiomyocyte so that the cardiomyocyte contraction becomes bigger and bigger. The muscle contracts better. That is the normal endothelial myocyte interaction. But when you give TNF alpha, for example, the TNF alpha blocks, because of the ROS, they block the nitric oxide, and that benefit goes away. And when they put empagliflozin in this same broth, they found that the TNF effect was blocked by EMPA, and again, that contraction was restored. Now you will say, what about this? We are clinicians, we are seeing patient, what is this mouse thing talking about? The point is different. Point is, endothelial dysfunction, we always know, sets very early in diabetes, hypertension, dyslipidemia, smoking, quite early. When we just say that the risk factors are there is some endothelial dysfunction, stiffness of arteries. And many often we find quite early in diabetes, patients have cardiomyopathy. We say, okay, must be blocked, go and get an angiogram. Angiogram, normal. We will say microvascular disease, diabetic primary cardiomyopathy. We say so many terms. Today we know there's an unknown and very serious interaction between endothelium and myocardial cells. What is it? We really don't know, but there's a good interaction. But it points out to one thing. If you have endothelial dysfunction, you are likely to have more of myocardial dysfunction. So very early, if you use drugs that prevents endothelial dysfunction by taking care of multiple risk factors, it is likely that we are going to prevent cardiomyocyte damage and heart failure. Maybe its progression. Start SGLT early. I don't know. Just think about that concept. Finally, last one I thought is very interesting. Again, volume reduction, good or bad. We know whenever a patient comes to the ICU, dyspneic, we give IV Lasix, right? IV diuretic, loop diuretics are one that we knew. Recently, there's been a change of concept. This is written by Michael Felker. He's from North Carolina. Very interesting article. And then he followed up with the data. We know that these IV diuretics are life-saving, right? But when we looked into the data, the mortality long-term, all these IV loop diuretics increase mortality or were not beneficial for survival. I repeat, all loop diuretics in the long run increase mortality. Why? So they were at least not shown to be beneficial. They save life at that point of time. But long-term, they don't do anything on the long-term survival. Why? We didn't know. And that is why I say that we should understand the difference between congestion and volume, right? Easy to understand, that's a Mumbai road, huge volume of traffic, congested. So we say, reduce traffic, cut out half the cars. You cut out half the cars, but that narrow road is still congested. So it's not just the volume, congestion is different from volume, right? Depends on the road condition, it's volume and congestion are not always mutually exclusive. Wayne Miller wrote a very beautiful article that came in circulation 2 years back, and it put out a very new postulation, and he showed that if on the y-axis you put CVP, let's say right atrial pressure, and on the x-axis you have blood volume, right? Blood volume. So blood volume, we put a line at 0, euvolemia. So anything onto the left is low volume, anything onto the right is high volume. Now we put a cutoff mark of CVP at 10, right? 10 or 12. So you have, this is 1,500 patient data, healthy people's data, and including patients. They found there are a large number of patients in that red box who are hypovolemic but have congestion. And again, you have a large number of patients who are hypervolemic but not congested. So in human physiology, somehow congestion and volume doesn't go hand in hand. And that brings us to DAPIHF data. If you look into it, see about what, 93% got diuretics. So which means they were all congested, they were decongested with diuretics and they became fine. They were all class 2 and class 3 when they entered the study, right? So they were not in class 4. So congestion relieved by diuretics. So here we should understand, basically we are talking about SGLT2. What is it? It's a diuretic, takes away sodium through urine, right? But then the point is that SGLT's effect on blood volume we know is quite low. But its effect on interstitial volume somehow is significant. Today we are talking about interstitial fluid retention in a big way, not just in the leg, but in the myocardium. For example, if you have a myocardium which is full of fluid in the interstitium, it is likely to be less supple, likely to be poor contractility, and likely to end up in heart failure with preserved ejection fraction. So at the end, these are the points to ponder. Post-CABG diabetic, even if he is fine, think of it. Should I put him on a diabetic, right? Should I put him on an SGLT inhibitor? Obese, breathless diabetic. Okay, try to see, does he have heart failure? If he does have heart failure, think about ARNI, melanocorticoid antagonism, and SGLT inhibitor. Endothelial, that is all theoretical, but today start thinking about endothelial cardiac cell connection, which means if you think that the patient has multiple risk factors and is likely to develop some kind of event later, think about it, not just events. That dysfunctional endothelial cell might contribute to his dysfunction of cardiomyopathy. So maybe drugs that improve endothelial function by cutting out multiple risk factors like SGLT2 may be beneficial. And finally, seeing is believing. Yes, we have seen that these agents do improve left ventricular function by imaging. Congested euvolemic doesn't categorize you are congested but euvolemic, and understand that simply dehydrating them with pure diuretic may not help in the long run. It might save his life at that point. So try to add up drugs that actually decongest and not just volume deplete. Don't just take home a knowledge, use them. Thank you for your time and attention.
Beta blockers are useful. Over and above that, SGLT2 have a favorable impact. Nicely emphasize, re-emphasize. Number one. Number two, the endothelial cardiomyocyte crosstalk, functional crosstalk. How it is tempting to speculate it can be favorably influenced by the SGLT2 inhibitors. And lastly, how do they score over even the diuretics? That is, depleting the extracellular or the interstitial fluid volume and preserving the intravascular volume, as has been highlighted by some mathematical models, convincing models. So thank you, Tiny. Without wasting much time, I think we'll straight away go to the questions. I'm sure both of you have a lot of questions. Very interesting presentations by powerful speakers in the country. This is to Dr. Tiny by Mohan. As GPs, we are used to looking at EF and diastolic dysfunction. The question is, A, what should we start looking from an echo? Number two, SGLT2 in non-diabetic heart failure or people with IGT.
So we'll start with one by one. The first is that we are used to looking at, see, we always say this is hidden heart failure. You know, a lot of patients will come with, just for echo by the physician. We would do an echo, detail, write everything. Intuitively, physician would read ejection fraction 50%. Oh, so your heart is normal, send him back. And today we know that all of us were wrong. A large number of them has heart failure with preserved ejection fraction, where ejection fraction is just one factor. So even if you can't go through all the diastolic dysfunction parameters, just look at two things. One, if there's a left ventricular hypertrophy with a large left atrium, you're very likely to have a diastolic dysfunction, because in diastole the heart is not relaxing properly, the heart is hypertrophied, and there is a left atrial enlargement. So large left atrium, easy, left atrial size and aortic size in echo should be same, okay, like 30, whatever. You see that the left atrium is far more than the aortic size, and you have a left ventricular hypertrophy. Simple again, left ventricular wall should be not more than 13 millimeters, more than 13. You can speculate that it's likely that he has got partly symptoms, maybe HFpEF, right? And these are patients who are likely to be hypertensive, likely to be diabetic, likely to be ischemic, and very often they have atrial fibrillation. So that is how we go rather than looking just at the ejection fraction. Your comment is very well appreciated. What should we start looking for in echo, right? SGLT inhibitor and non-diabetic heart failure, yeah. See, non-diabetic, for example, DAPA-HF has about 58% patients who were not a diabetic. A lot of people have criticized telling that of those who were said to be non-diabetic, there were some IFG. But I don't think that would have made a major difference because the trend is clear. Diabetic or non-diabetic, it tends to show that you benefit in heart failure by giving. Obviously, if you have an IGT or an IFG and a heart failure, probably SGLTs will be far forward in our line of prescription. Any comments?
Thank you, Trini. I think before we take on to other questions in the same vein, I want to ask you a very provocative question. Now, all the trials and observational data, the huge real-world data have established that SGLT2 inhibitors as a class, they are effective in cardiac failure. But only in empiric outcome, you had the CV mortality. Superficially, you can always attribute it to the benefit with respect to heart failure. But from the data that you had from the animal experiments, do you think that there could be something much more for the molecule per se with respect to the CV and all-cause mortality besides the uniform benefit of all the SGLT2 inhibitors?
Right now, my take would be that from the data we have on the three, just the three, that is CANA, EMPA, and DAPA, they look like they are a class effect. They move in the same direction, right? We might have bits of data coming from one molecule and bits of other coming from another molecule. Understand that if we actually look as a medical scientist into EMPA-REG, CANVAS, and DAPA declared TIMI, they're all different trials. One had full of cardiovascular disease, and one had about 40% cardiovascular disease and 58% who were like primary prevention. So we are not looking into same homogeneous group, but overall, if we look into the Lancet meta-analysis, it is very clear. If patient has multiple risk factors, these drugs are safe. That is why these trials were done. They are safe, they are right on the midline. If patient has any atherosclerotic cardiovascular disease, we significantly benefit, all three. Okay. If there is no heart failure, we benefit. If there is heart failure, we benefit by prevention of further episodes of heart failure. That is it. So right now it shows like all these three. I'm not talking about ones which are not proven. We never write those which are not proven. These three look like they move in the similar direction. What would be your take on that?
I completely agree, and there's another angle to it is also that, you know, if there's a recent paper looking at both the EMPA-REG, the DAPA and the CANVAS and other such trials, and they found that despite the fact that one group had CV was the outcome and one group had a drug A and one group had placebo, the glucose levels were much better in the drug group compared to placebo. Because every clinical trial has got a rescue criteria which goes up to fasting of 270. So in the placebo group, the blood sugars allowed to drift up to 270 before treatment was augmented. So this resulted in a small glycemic difference. And the new review of these trials suggests that that glycemic difference also has to be taken into consideration to interpret the benefits of the trial. So like Dr. Tiny said, there are many, many aspects of these drugs, and these are different trials, and we need to choose patients based on multiple risk factors, established risk, and of course extra glycemic and glycemic criteria.
A quick question, any recommendation for any particular SGLT2 in patients with atrial fibrillation?
Atrial fibrillation. No, not really. I am not aware about any head-to-head trial data between the SGLT inhibitors, but overall, since SGLT inhibitors reduce sodium load, reduce blood pressure, obviously they take away the left ventricular, reduce the left ventricular mass index. So as left ventricular thickness comes down, AF tends to be rarer and rarer. And one thing that we should have in mind when we have an AF should be, aim should be to reduce the left atrial size and take care of the left ventricular hypertrophy. If we do that, the background that produces AF would likely to come down.
We will have just a couple of questions which are there in the iPad, one for Uni and one for Tiny.
The question is, can the volume overload issue of glitazones when combined with gliptins be overcome with SGLT2 inhibitor? I think this is an important topic because pioglitazone increases the risk of heart failure. Can you overcome that by adding with SGLT2 inhibitor? You know that saxagliptin increases the risk of heart failure. So can you overcome that by combining with an SGLT2 inhibitor? Well, we don't have data to clearly suggest that, but I want to add the point that gliptins and gliflozins have got very good synergy. SGLT2 inhibitors actually increase the glucagon level through a complex mechanism. DPP4 inhibitors actually bring down that glucagon level. SGLT2 inhibitors actually cause weight loss, whereas some DPP4 inhibitors like saxagliptin increase the risk of heart failure. So there are lots of points of synergy between these two drugs, and it might be good to even add these two drugs in as a combination. We are not looking at this or that, but looking at low dose of several drugs may be an option.
Uni, at another point, in the same vein that you said, I think DPP4 inhibitors, there are some soft data to suggest they act on the distal convoluted tubule. So distal natriuresis has been observed to whatever beneficial effect. On the one hand, it might have a marginal diuretic effect. Number two, it may not detrimentally impact the tubuloglommular feedback also. Your question, and then we'll wind up.
I think one question is here, Remo will be there, the same CV benefit, we don't know. See, understand that we are just not talking about sugar lowering, right? This kind of drug A, drug B, drug C, Dr. Unni has discovered a new drug which will lower sugar. That is not the point. The point is, these drugs, we tried to see are they safe. And we ended up with the results showing that not just safe, they are far better than the standard therapy. And that's why we are today debating and wasting our time. So they showed that they improve cardiovascular outcome, whether it is MACE or whether it is heart failure. None of these things have been shown as of yet by the molecule we are talking about. And I will not recommend writing this for the purpose of preventing cardiovascular disease. No, we don't know. We have to wait for the data. The other two questions were on side effects. Obviously, in a forum, we would always talk about good things. We should also know about the bad things. We should know about the urogenital infections, which Dr. Unni showed so elegantly. We should understand that at least one trial with canagliflozin showed lower limb amputations, fractures, and all kind of stuff, so we are careful. Of course, the Credence trial did not show, but Credence had a cutoff where they tried to take away all those patients who are likely to get into a lower limb problem. That is true. And understand that these drugs also take away sodium in urine. So many often we find that the question that is asked is, people on antihypertensive, they may be on a telmisartan hydrochlorothiazide combination, or telmisartan chlorthalidone combination. And for his diabetic control, the physician, without realizing, adds something. You add 10 milligrams of empagliflozin, 25 of empagliflozin. What happens is that he might get into dehydration, especially in summer times, because he loses a lot of sodium. Already you are giving me a diuretic, and you add up something more.
One more question again to Dr. Tiny, and I'll also comment on that. That question is now, can you use SGLT2 inhibitor in anasaka, hypoproteinemia, proteinuria, stage 4 kidney failure, stage 3 kidney failure? What's your take on that?
See, after Credence, the whole concept is coming down, and people are talking about up to the level of GFR of 30, you can use it. Basically, we have seen that these drugs are like RAS inhibitors, very good in preventing, slowing down the graph of declining renal function, right, in renal failure. So I envisage that probably a couple of years later we will find it's just like RAS inhibitors, there will be no GFR restriction on starting SGLTs, as long as you can make sure that patient is euvolemic and you see that he's not dropping his blood pressure and he's fine. I think that is a time that is going to come in the near future, where nephroprotection. But other indications, anasarca and all that, or hypothyroid with edema, I don't think we should try it out because there has not been proven.
I think Dr. Vignesh has made in a lighter vein, compared the diet of Sweden and Kerala, and then asked your opinion with respect to oil. Is it the coconut oil, the tapioca, or the fish that is making the difference?
Or the genes. Truly speaking, we don't know whether it's in the genes, but if you come to our intensive care unit, you'll be surprised to see that so many people between the age of 40 and 45, they're all working in the IT with MIs, they come. And the first question they come, these young MIs are that, doctor, I have nothing. I have no diabetes. I regularly check no blood, cholesterol, no blood pressure, and I regularly walk. And when you interview them, what you find is many of them are IFG. They consider it normal. They have a blood sugar of maybe 112, 115 IFG. They have a little elevated HbA1c. They have an LDL cholesterol which is anywhere between 100 and 130, not normal. Okay, they have blood pressure which is something like 140 over 95, mild hypertension. And they say, finally you ask them, say, I just smoke 2 cigarettes a day, morning when I go for the toilet, right? So they have, in Kerala we find they have multiple low-level sub-threshold risk factors. They are not truly risk factors. They have IFG, they have borderline hypertension, they have little LDL elevated, non-HDL are always high, and they might be smoking 1 or 2 cigarettes. I think combination of this plus the stressful life is responsible. Coconut oil, we always tell them that as of now, we recommend do not take coconut oil because it contains a lot of saturated fat. Is it the only reason why Keralites get a heart attack? I don't know.
And we'll have to look at these foods together. For example, Dr. Kuchupillai from All India Institute told me once that, you know, when Keralites eat tapioca, they eat it with a particular acidic oil, and that acidic oil may have an effect on enzymes, and that might interact with the way the carb is actually presented to the body. So it's not only eating tapioca or coconut oil and fish, but it's all how these things are mixed and mashed. So nutritional epidemiology is a very complex topic.
So I thank both Dr. Unikrishnan and Tiny for not only for the brilliant presentation, but for the way the question answer session has been so convincingly answered with data and their own experience. Give a big hand to them. So with this, I wind up the session and then hand it over to